So coming to dementia, almost 1/5 of the Parkinson patients have memory issues, and the prevalence of this condition is much higher in the older patients than in the younger onset. And once the patient has dementia, then the prognosis is poor and survival is less. And these patients do not respond well to L-DOPA and they experience more side effects. So in a patient with dementia, make sure the dementia is not caused by other disease like vitamin B12 deficiency, hypothyroidism, neurosyphilis, normal pressure hydrocephalus or mass lesions. Treat the dementia as you would treat the other dementias. Coming to depression, this affects a majority of the Parkinson patients. Almost 50% of them experience depression, and this is related to the duration as well as the severity of the disease, and it's much more during the off periods of levodopa response and lives with improved control of motor symptoms. And this is related to the loss of frontal dopaminergic projections or sensory serotonin deficiency, or is a psychological response to the Parkinson's disease has not yet been resolved. Patients do very well with the treatment of the depression. If apathy is a major feature, give a stimulating antidepressant. If sleep disturbance is a major feature, you can give some sedating antidepressant. Apathy. What is this apathy? It's not just laziness. You have to realize that this patient is not just lazy, but there is a neurological basis which underlies this phenomenon where the patients do not want to do anything. These affect the normal patient's daily life, and they are often confused as well as depressed. The treatment can improve by asking them to have an increased activity. You can give them some structured activity programs, so they will be occupied and the apathy will be less. Caffeine, coffee, tea can improve the apathy to some extent. Modafinil is a drug which is very helpful in these conditions. Next important condition is hallucinations and psychosis. This sometimes can lead to a lot of problems. I had a patient who developed hallucinations that someone is coming to rob his belongings. And this was at about 11 o'clock in the night, and he called his spouse and told her. She said there is nobody there because he was hallucinating, and she said nobody is there, you go to sleep. What he did was he rang up 100, and probably police came home because they have to see what is happening. He has rung up with the emergency, and then to find he was confused, he was talking to them about this person who was there when he was not there. And another occasion he called his neighbor instead of the police, telling there is somebody at home. They also develop paranoid tendencies, and what happens, they think the people at home have stolen their money, their clothes, and sometimes they become very suspicious of their partners also. This can make the life hell for others who are living with them. So we should talk about this and we should try to help them as much as possible. And the visual hallucinations sometimes are in the form of insects crawling over the food. So they are just not able to eat. What if I find my chapati having ants all over? I will not be able to eat. So if some drugs are producing it, stop the drugs, the hallucinations definitely improve. And these are much more when there is a associated dementia, advanced age, or premorbid psychiatric illness also. And if you are putting them on high doses of levodopa, this can occur, apart from certain other drugs. Then when there is an associated infection, either urinary tract of pulmonary infection or some condition which can make things worse like metabolic encephalopathy or a cerebrovascular events, the hallucinations can get worse. If it is because of the drug, stop the drug. It can be either amantadine anticholinergic dopamine agonists or COMT inhibitors, or reduce the dose of L-DOPA. This is not subsiding, then you can add clozapine or quetiapine, where the hallucinations will improve to a large extent, or get the help of a psychiatrist if necessary. Sleep disorders are a big issue in patients with Parkinson. Why does this become an issue? Because they sleep at times which they are not supposed to sleep. They do not take their medications regularly because they sleep at odd hours. The night sleep is affected, and so what happens is daytime they sleep excessively. They sleep at say maybe from morning 8 to 11 o'clock, and they have to take the drug at 9 o'clock. So this is an issue. Apart from that, the night sleep is fragmented. They do not sleep continuously. There are small bits of sleep, awake, small bits like that. And they also have difficulty falling asleep. That's usually at night. And daytime they sleep much more. So you can see this man sitting and sleeping. This is a very common condition in Parkinson's. Apart from this, there is a condition known as restless leg syndrome, where they have a tendency to keep moving their legs because of creepy crawly sensation in the legs. That also affects their sleep. As mentioned earlier, this REM behavior disorder can produce very scary dreams, and they act it out, and this disrupts the sleep. If you find a patient having sleep apnea, then you should think of atypical Parkinsonism rather than Parkinson's disorders. Dyskinesia movements, involuntary movements can affect their sleep, and sometimes because of their sleep-wake cycle is altered in dementia also, they have sleep problems. So, in sleep problems can be because of the motor symptoms, because of autonomic symptoms, because of our drugs, or because the sleep-wake cycle is affected because of the old age, and circadian rhythm disorders can also disrupt the sleep-wake cycle. So, the treatment of it is if the patient is sleeping small amounts of time and then getting up and sleeping again, then you can use a controlled release carbidopa levodopa. You can use a sedating antidepressants to sleep better, or clonazepam. They are making a lot of noise during night and they have vivid dreams and disrupting everybody in the house. Then you can reduce the dopaminergic medications near bedtime and give clonazepam. All these will come down. Most important condition is orthostatic hypertension, because of which they may fall, fracture and get bedridden, and things go on for a deep dive. Orthostatic hypotension, this is caused either by the disease or by the drugs which are used to treat it. Pharmacological agents which are helpful in increase the blood pressure like mineralocorticoids can be used, but they take usually several weeks to become effective. The dose is a fludrocortisone 0.2 milligram per day increased to 0.4 milligram per day, and other appropriate measures like promethazine can be used, and dose administration of midodrone is about starting with 2.5 milligram at breakfast and lunch, and then increase by 2.5 milligrams daily, minimum 10 milligrams 3 times a day, can be given 3-hour intervals if needed, but not more frequently. And what happens is you can ask him to drink a lot of water. To some extent the hypertension will be raised. If the patient is on multiple drugs, especially treatment of hypertension or other cardiac drugs or drugs for prostate disorders, then they can also contribute to the orthostatic hypertension. In patients who have recurrent orthostatic hypertension, it is very essential to evaluate a complete autonomic functions.